Hey everyone, I'm so glad you're joining me for this explainer today. We are going to dive into a seriously fascinating, incredibly complex area of surgical oncology, the management of hard palate and upper alveolus cancers. Specifically, we're looking at the ultimate surgical master key used to defeat them, the WEBER-FERGUSON incision. If you've ever wondered how on earth surgeons deal with aggressive tumors hiding way up in the roof of the mouth and the upper jaw, well, you are in the exact right place. We're going to break down the anatomy, the surgical routes, and the mind-blowing reconstructions required to help these patients heal. Okay, let's just jump right into our game plan for today. First, we'll tackle the hard palate challenge. Then we'll look at the different routes to the tumor. Third, our main event, the WEBER-FERGUSON incision itself. After that, we'll cover some really clever cosmetic and surgical extensions. And finally, we'll wrap up with rebuilding after the resection. Let's go.
Part 1. The Hard Palate Challenge.
So, let's talk about the battlefield itself. The hard palate, the roof of your mouth, isn't just your run-of-the-mill tissue. It's a highly specialized, rigidly fixed structure that presents a massive mechanical headache for surgeons. Think about the floor of your mouth for a second. That tissue is thin, it's pretty atrophic, and it moves around easily. But the hard palate, that mucosa is incredibly thick, highly keratinized, and practically superglued to the bone underneath. This creates a really tricky situation, what we call the surgeon's dilemma. Because this tissue is just so dense and tightly anchored, early-stage cancers like squamous cell carcinomas can easily fly under the radar. There's often no obvious, ugly growth right away. Instead, a patient might just notice a smooth, firm little bump. So this tough anatomical barrier actually masks the early spread of the disease.
And because it flies under the radar, the tumor can spread upward and backward. It's literally like a hidden fire burning right behind a wall. By the time a patient actually goes to the doctor, they're dealing with symptoms that seem totally unrelated to a simple mouth sore. For instance, if the tumor grows superiorly, upward into the nasal cavity or the sinus, the patient might get a constantly stuffy nose or sudden nosebleeds. If it pushes posteriorly into the muscles you use for chewing, they might develop trismus, which means they literally can't open their jaw. If it goes sideways, it can mess with the eustachian tube, causing fluid in the ear or even hearing loss. And, perhaps scariest of all, if it invades the facial nerves, it can cause the roof of the mouth to go totally numb or even stop the patient's eye from blinking naturally. These are massive, terrifying symptoms, all stemming from a tumor hiding in the roof of the mouth.
Moving right along to Part 2. Routes to the tumor.
Okay, so how do we actually get in there to fix it? Well, if a tumor is small or benign or sitting right in the middle near the front, surgeons can just go in through the mouth. Easy enough. But what if the tumor is massive or buried deep in the back or invading all those surrounding structures we just talked about? We need external access. Let's look at the first major route, the lateral rhinotomy, which you'll also hear called the Moore approach. Picture this. The surgeon's blade starts right near the inner corner of the eye. Then, it runs smoothly down that natural smile line, the nasolabial crease, and finally curves inward, hugging the crease of the nostril. It's an incredibly clever approach. It lets the surgeon basically peel back the facial tissues to remove part of the maxilla, all without ever having to cut the patient's upper lip. But sometimes even that just isn't enough room to work.
Which brings us to Part 3. The WEBER-FERGUSON incision.
So, what happens when a tumor is sitting way out to the side near the cheekbone or buried really deep in the back? The Moore approach simply hits a wall. The window is just too small. The surgeon needs total, 100% unobstructed access to the upper jaw. Enter the absolute star of our explainer today, the WEBER-FERGUSON incision. By definition, this is a surgical approach that takes that lateral rhinotomy we just talked about and extends it by explicitly cutting straight through the upper lip. This one, bold move, is the ultimate master key. By dividing the lip, the surgeon can literally fold the soft tissues of the whole face back, kind of like opening the page of a book. This completely exposes the entire maxilla and hard palate, letting the surgeon safely remove the absolute most stubborn, deeply entrenched cancers.
And the visual difference between these two techniques is honestly night and day. With the Moore approach, the cut completely stops at the nose. The lip stays totally intact, but the WEBER-FERGUSON just keeps going, slicing right down through the upper lip. And you know those extra few centimeters of incision? They are an absolute game changer. It takes a surgery from feeling like you're working through a narrow, dark tunnel to operating in a wide-open, fully visible anatomical field.
All right, Part 4. Cosmetic and surgical extensions.
Now, as you probably know, surgical techniques never just stay stagnant, right? surgeons quickly realized they needed to tweak this approach. They wanted to minimize those visible scars for the patient, and they also needed ways to chase down tumors that had spread way out of bounds. Back in what we can call Era 1, the classic WEBER-FERGUSON cut went straight down the side of that little groove above your lip, the philtrum. It got the job done, sure, but cosmetically, that scar was super obvious. Then Era 2 rolls around with the Hernandez modification, and wow, this was a stroke of absolute genius. Instead of cutting straight down, the incision now curves slightly up inside the nostril, into the nasal sill before dropping down. This sneaky little detour hides a big chunk of the scar in the natural shadows of the nose. The cosmetic payoff is huge. Finally, Era 3 brings us to massive resection extensions, used when a tumor has just completely broken all the rules.
So, when the cancer does break those boundaries, the surgeon has to bring out the heavy artillery, massive resection extensions. The first one is the Dieffenbach extension. This is a sideways cut that sweeps right out toward the cheekbone. Surgeons have to use this when the cancer has ruthlessly invaded the deep space behind the jaw, requiring them to take out most or all of the upper jaw. On the flip side, we have the Lynch extension, which reaches straight up. If the tumor is climbing up into the ethmoid sinuses right up near the eyes, this upward cut gives the surgeon the clearance they desperately need. The crazy thing is, a surgeon has to be ready to pivot on a dime and deploy these extensions the exact second they realize how far the cancer has actually gone.
And that brings us to our final section, Part 5, Rebuilding After Resection.
Okay, so the cancer is out. The margins are clean. Huge relief, right? But the surgery is really only half over. Now comes what is arguably the most intricate step of the whole shebang, rebuilding the patient's face, their ability to chew, and their ability to talk. To pull this off, surgeons rely on classification systems. Think of these as the architect's blueprints for facial reconstruction. Now, the crucial point here is understanding what these systems actually measure. The OK system, for example, is super focused on the teeth and the gums. It asks questions like, is it just the roof of the mouth that's gone? Did we lose a canine tooth, or did we lose the entire palate? The James Brown system, though, looks at the whole geometry of the empty space. It measures how far the defect spreads horizontally and, crucially, vertically. Like, did the surgery leave a gaping hole right into the sinus, or did it go all the way up to the floor of the eye socket?
Once the surgical team maps out that defect, they turn to their reconstruction arsenal. Now, if it's a smaller defect and the patient still has some good, strong teeth left, an obturator is a fantastic option. It's basically a custom removable prosthetic that just snaps right into place and seals off the roof of the mouth. But what if we're dealing with a massive WEBER-FERGUSON resection where the entire upper jaw had to go? An obturator simply isn't going to hold. You need actual living tissue. This is where free flaps come in. A free fibula flap is practically magic. The surgeon takes a piece of bone from the patient's leg and uses it to literally rebuild the jaw. The best part? It allows the patient to get actual dental implants later on. Or if they just need to fill a massive space with soft tissue but don't necessarily need bone, they might use a flap from the forearm or the thigh to brilliantly seal the cavity and make the face look completely natural again.
But listen, even with all of these mind-blowing techniques, the field of surgical oncology is always evolving, and some really intense debates are still raging today. I want to leave you with a question that's currently echoing through tumor board meetings all over the world right now. Imagine a hard palate cancer that has aggressively invaded incredibly deep behind the jaw. We call this high supernotch disease. What is the right call? Do you go in guns blazing with an immediate radical WEBER-FERGUSON approach? Maybe throw in a Dieffenbach extension just to guarantee you get clean surgical margins right then and there. Or do you hold off? Do you hit the patient with chemotherapy first to try and shrink the tumor, knowing you risk the disease spreading, but maybe, just maybe, you save some vital facial structures? It's the ultimate tightrope walk between totally eradicating the disease and preserving a human being's quality of life. What would you choose? Thank you so much for exploring this with me on The Explainer today. Keep questioning and keep learning.